So you are standing right there at the bedside.
Right.
You have your stethoscope around your neck. The room is quiet, and you lean over your patient.
Yeah, getting ready to do your assessment.
Exactly. You place the chest piece down, expecting to hear that clean, textbook, reassuring lub-dub.
Which is always the hope.
But instead, what hits your ears is this chaotic, turbulent whoosh.
Oh, man, yes.
And instantly, that wave of new nurse anxiety just spikes in your chest. You're staring at the patient, wondering, what on earth is happening inside their chest, and more importantly, what you are actually supposed to do about it.
It is a totally terrifying transition. I mean, going from the controlled safety of a nursing textbook to the reality of a living, breathing human being who relies on your assessment, it can feel completely overwhelming.
It really can.
Yeah.
Well, welcome to the Super Nurse podcast created by Brooke Wallace.
Yes, welcome.
Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
And we should be incredibly clear right up front, we are not Brooke Wallace.
Definitely not. But we are working directly from her clinical notes today.
Right.
This entire conversation is built from her bedside knowledge and her signature teaching style. Our goal today is to help you take all that abstract pathology you memorized for nursing school and actually apply it to real patient care with confidence.
Exactly. And if you are an active learner who likes visuals, we want to invite you to subscribe and watch the video version of this on YouTube. The link is right in the description on our channel, which is called Super Nurse AI.
So today's mission is to completely demystify heart sounds. We are specifically breaking down the pathophysiology, the bedside assessment, and the nursing interventions for aortic stenosis and mitral valve stenosis.
And to do that, we really have to start with the actual anatomy of auscultation.
Right. Which I will admit, in my early clinicals, I am totally guilty of using the random placement method.
Oh, we've all been there.
I mean, I would just sort of move my stethoscope around the left side of the chest until I heard something that vaguely sounded like a heartbeat and then just call it a day.
It happens all the time. But clinical experience shows over and over that randomly placing your stethoscope just won't work for catching complex murmurs.
Because you're not listening in the right spot for the fluid dynamics.
Exactly. You need specific anatomical landmarks. And we listen in these precise areas, not necessarily because the valve is located exactly an inch below that spot, but because that is the direction the blood is flowing.
The sound radiates along the pathway of the blood.
Right. So we use the APTM, mnemonic APETM, to remember these locations. All people enjoy Time magazine.
Okay, let's unpack this framework so you can actually visualize it on your patient's chest.
So A stands for aortic. You find this at the second intercostal space, right? Sternal border.
Right, and notice this is the only valve you auscultate on the right side of the sternum.
Exactly. Then P is for pulmonic. You just slide your stethoscope straight across the sternum to the second intercostal space on the left sternal border.
And E is for Erb's point.
Right, that's the third intercostal space, left sternal border. Then T for tricuspid, moving down to the fourth or fifth intercostal space, still hugging that left sternal border.
Okay, so we're working our way down.
Yeah. And finally, M for mitral, which is also known as the apex. This is the fifth intercostal space, but you move outward toward the armpit, landing at the midclavicular line.
You're essentially tracing a rough backward Z shape down the chest. But I want to talk about the physical tool we use to listen at those spots.
The stethoscope itself.
Yeah. It has two sides for a very specific reason. I always think of it like listening to a stereo. The diaphragm, the bigger flat side, is for the treble.
Right, it picks up the high-pitched sounds.
Exactly, like your standard S1 and S2 and your systolic murmurs.
And you really need firm pressure to hear those high pitches clearly.
Which brings me to a massive mistake I used to make. So the bell, the smaller cup-like side, is for the bass. It picks up low-pitched sounds like an S3 and S4 and diastolic murmurs.
Yes, the low-frequency stuff.
Well, when I was a student, I thought pressing harder meant hearing better. So I would take that bell and just jam it into the patient's ribs.
Oh, no. Yeah, that is so common, but it defeats the whole purpose.
Right. Because if you press the bell hard into the tissue, the patient's skin just stretches tight across the cup. It effectively turns the skin itself into a makeshift diaphragm.
Yeah, by pressing too hard, you completely obliterate the low-frequency sounds you were trying to find in the first place. The bell requires very light pressure.
Just enough to create a seal against the skin.
Exactly. Firm pressure for the treble, light pressure for the bass.
Okay, so now, just to set our healthy baseline before things go wrong, normal, high-pitched sounds are S1 and S2.
Right. S1 is the love. That's the sound of your mitral and tricuspid valves snapping shut.
And S2 is the dub. The aortic and pulmonic valves closing.
They represent the normal, healthy rhythm of the heart's doors shutting tightly. And what we know from practice is that when blood flows normally through a wide-open, healthy valve, it is totally silent.
So smooth flow makes no sound.
Right, so when you hear a murmur, that chaotic whoosh, you are hearing friction. You are hearing turbulent blood flow.
And we can categorize that turbulence into two main problems, regurgitation and stenosis. Let's translate the medical jargon into plain English for a second.
Good idea. So regurgitation is a problem with a closed door. The valve is supposed to be completely shut, but it's floppy or incompetent, meaning blood leaks backward through the cracks.
But stenosis, on the other hand, is a problem with an open door.
Yes.
I always picture stenosis like a massive crowd of people at a stadium trying to leave after a concert. The main exit gate is supposed to be wide open, but it's jammed and only pushed open a tiny crack.
That's a great visual.
Right. Thousands of people are shoving, there's a ton of pressure, and people are violently squeezing through one by one. Or think of taking a garden hose on full blast and pinching the middle of it.
Yeah, the water has to force its way through that narrow, stiff opening, creating a loud, angry, high-pressure spray.
Exactly. So hemodynamically, what's happening?
Well, the valve leaflets have become stiff, calcified, and fused together. They physically refuse to open all the way.
So the heart has to work harder.
Way harder. Because the opening is so narrow, the heart muscle behind it has to work exponentially harder to eject the same volume of blood.
Which brings us to the first major condition, aortic stenosis. The mechanics here make total sense. The aortic valve is the ultimate gateway from the heart to the rest of the body.
Right. It sits between the left ventricle and the aorta.
And it is supposed to be wide open during systole, the active squeezing phase of the ventricles.
Since the stiff valve is actively resisting that massive squeeze of the left ventricle, aortic stenosis creates a systolic murmur. You'll hear the turbulence right between S1 and S2.
So if I place my stethoscope at the right second intercostal space, what am I actually listening for?
You're listening for a harsh, medium-pitched sound. Clinically, it's described as crescendo decrescendo or diamond-shaped.
Meaning it gets louder than softer.
Right. As the ventricular squeeze starts, the sound is quiet. It builds to a massive roar as the pressure peaks and then fades as the squeeze finishes.
Wow.
And because the blood is shooting through that tiny opening under such immense pressure, the sound often travels. You can frequently auscultate this murmur radiating all the way up into the patient's neck, right over the carotid arteries.
That pressure creates a massive physical toll on the heart itself, too.
Yeah.
I mean, if my left ventricle is constantly trying to push blood through a tiny, stiff opening, it's essentially lifting incredibly heavy weights all day, every day.
Yeah, it's a huge workout.
Like a bodybuilder, that muscle wall is going to get totally jacked, which is left ventricular hypertrophy. But a thick, massive muscle wall isn't necessarily a good thing for a heart, is it?
It's actually a terrible thing.
Yeah.
A hypertrophied ventricle becomes incredibly stiff and non-compliant. It loses its elasticity.
And that thick, stiff muscle wall frequently produces its own abnormal heart sound, doesn't it? The S4.
Yes, the atrial gallop. The S4 happens right at the very end of diastole, a split second before S1. The atria give one final squeeze, the atrial kick, to push the last bit of blood into the ventricle.
But the wall is too stiff.
Exactly. Because the ventricular wall is so thick and unyielding, it literally vibrates under the sudden fluid pressure.
Brooks' clinical notes have an amazing memory trick for this. An S4 sounds like a grumpy old man complaining right before he has to go to work.
I love that one.
It's so accurate. It happens right before systole, right before the heavy lifting. And it is the literal sound of a stiff, unhappy wall being forced to expand.
Which perfectly brings us to the patient's symptoms. Because the blood is struggling so hard to get through the aortic valve, the total volume of blood actually reaching the body, the cardiac output, drops significantly.
So the classic triad of symptoms for aortic stenosis directly reflects that lack of blood flow.
Yep.
Your patient will show exertional dyspnea, like they are incredibly short of breath just walking to the bathroom because their working muscles aren't getting enough oxygenated blood. They might have syncope, meaning dizziness or fainting, because their brain is being underperfused. And they will likely experience angina or chest pain.
And that chest pain happens because that massive hypertrophied heart muscle has grown so large that its oxygen demand outpaces its own blood supply. The muscle is literally starving itself.
Okay, so aortic stenosis is the ultimate roadblock on the way out of the heart. But what happens if the entryway is the thing that's blocked?
That's when we move to mitral valve stenosis.
Right.
The mitral valve sits upstream on the left side, acting as the door between the left atrium and the left ventricle. It is supposed to be wide open during diastole, when the heart is relaxing and the ventricle is peacefully filling with blood.
But if the mitral valve is calcified and won't drop open during that resting phase, the blood has to force its way down into the ventricle.
Exactly, and that friction creates a diastolic murmur, heard after S2.
And the character of the sound shifts dramatically here, doesn't it?
It does. It isn't a harsh, high-pressure spray like aortic stenosis. It is a low-frequency decrescendo-crescendo rumble.
Oh, and because it's a low-frequency rumble, this is where you absolutely must use the bell of your stethoscope with very light pressure at the apex.
Yes. And we have a brilliant bedside technique to make that low rumble easier to hear. You ask the patient to roll completely onto their left side, the left lateral decubitus position.
Oh, to shift the heart.
Right. Gravity physically shifts the heavy apex of the heart forward, bringing it right up against the chest wall, which amplifies the sound for your stethoscope.
I just love when physiology and simple physics combine at the bedside. But we need to trace this plumbing issue backward. If the mitral valve is narrow and the blood sitting in the left atrium can't easily drop down into the ventricle, the blood has to go somewhere.
And blood is lazy. It always follows the path of least resistance. If it can't easily flow forward, it backs up. It begins pooling in the left atrium.
And what does that do to the atrium?
Well, as that volume increases, the physical walls of the atrium begin to stretch out like a balloon.
And when heart tissue stretches, the electrical pathways running through that tissue get physically distorted and damaged.
Which triggers atrial fibrillation. The atrium abandons its nice coordinated squeeze and simply starts quivering.
That's bad.
Very bad. This introduces a massive complication. When blood sits stagnant in a quivering chamber, particularly in the little pocket called the atrial appendage, it coagulates.
So mitral stenosis patients who develop AFib are at a highly elevated risk of throwing a blood clot straight to the brain and suffering a massive stroke.
Absolutely. And the backward domino effect doesn't stop at the atrium. Right behind the left atrium are the pulmonary veins, delivering oxygenated blood directly from the lungs.
So when the atrium backs up, that traffic jam extends immediately into the pulmonary circulation.
Exactly. The fragile capillaries in the lungs get engorged with high-pressure fluid, pushing plasma right into the alveoli,
causing severe pulmonary congestion and destroying the patient's ability to exchange oxygen.
which means we are no longer just dealing with a murmur, right? We are dealing with a systemic crisis. Research and clinical experience tell us that whether a patient is suffering from the downstream starvation of aortic stenosis or the upstream flooding of mitral stenosis, both paths ultimately end in heart failure.
So as a nurse, your assessment has to widen from the stethoscope to the entire body. You are aggressively monitoring for signs of decreased cardiac output and fluid overload.
You are auscultating the lung bases for crackles, indicating fluid backup. You're watching for pink, frothy sputum, which is the hallmark of severe pulmonary edema and an absolute medical emergency.
You are also inspecting the neck for jugular vein distension, assessing if the traffic jam has backed up into the right side of the heart and the venous system.
And you're checking the ankles and sacrum for pitting edema.
Okay, so let's walk through a scenario. Imagine you walk into your patient's room. They are sitting on the edge of the bed, trepoting, gasping for air, and their oxygen saturation is 88%. What is your immediate nursing intervention?
Well, before you page the provider, before you run to the medroom, you sit the patient completely upright.
Put that bed into high Fowler's position immediately.
Yes. You use gravity to physically drop the fluid down into the bases of the lungs, opening up the upper airways for gas exchange.
Sitting them up also temporarily decreases venous return to the heart, taking a fraction of the fluid workload off that struggling pump. Then obviously you apply oxygen to get that saturation up.
Right. And once the immediate airway crisis is stabilized, you have to look at the pharmacology. The provider is going to order medications to manage the physics of this failing pump, and you need to know exactly how they work. First up are diuretics, like furosemide.
The primary goal of a diuretic is to force the kidneys to excrete all that excess fluid suffocating the lungs and swelling the legs. By dropping the total fluid volume, you give the heart less fluid to push around.
Yep, taking the load off.
And a great memory trick for this. Furosemide ends in ID'd, and it makes the body dried.
I always use that one. They are incredibly effective, but they carry a major clinical warning. Furosemide is a loop diuretic, and its mechanism of action aggressively wastes potassium in the urine.
Which means you must actively monitor their daily potassium levels.
Exactly. If potassium drops too low, the electrical system of the heart becomes hyperexcitable, triggering lethal cardiac arrhythmias.
Next, we see beta blockers ordered, like metoprolol.
A beta blocker is designed to pump the brakes on the heart rate. By forcing the heart to beat slower, you extend the diastolic resting phase.
Giving it more time to fill.
Right. This gives the ventricles much more time to actually fill with blood before the next squeeze. Furthermore, a slower heart rate drastically reduces the amount of oxygen that hypertrophied starving muscle requires to survive.
You just have to monitor their heart rate closely to ensure they don't slip into dangerous bradycardia.
Always check that heart rate.
Then we have ACE inhibitors, like lisinopril. I call ACE inhibitors a chill pill for the heart.
That's exactly what they are. They act by relaxing and dilating the peripheral blood vessels.
Yeah.
This lowers systemic blood pressure, which we call decreasing the afterload.
So with the blood vessels relaxed, the struggling left ventricle doesn't have to push nearly as hard to get blood out into the body.
Right. However, ACE inhibitors are notorious for two side effects.
Yeah.
A nagging, dry, non-productive cough, and hyperkalemia, or elevated potassium.
Okay, you mentioned relaxing blood vessels to make pumping easier, but there is a massive, incredibly dangerous exception to this rule when we talk about vasodilators and aortic stenosis.
Yes, this is a point of critical safety. In a patient with severe aortic stenosis, administering a potent vasodilator, like nitroglycerin, can be lethal.
But if relaxing blood vessels usually helps the heart pump, why is it suddenly dangerous here?
Think back to our stadium analogy. The aortic valve is a stiff, heavy, nearly glued-shut door. The only way blood forces that door open is if the left ventricle has enough shear volume and pressure pushing behind it.
Which is a concept called preload.
Exactly. These patients are entirely dependent on that high preload to survive.
So if you give nitroglycerin, the blood vessels massively dilate, the blood pressure tanks, and the fluid volume returning to the heart drops.
And without that high-pressure fluid returning to the left ventricle, there isn't enough force to push that stiff valve open anymore. The door essentially slams shut.
Oh, wow.
Yeah, cardiac output drops to zero, and the patient crashes immediately. You have to manage their chest pain and blood pressure with extreme caution, prioritizing their preload.
Understanding that mechanism, why a standard chest pain protocol could harm a specific valve patient, is exactly what elevates a nurse from simply following orders to actively protecting their patient. And that level of critical thinking extends directly into your discharge teaching, too.
Definitely. When these patients leave the hospital, they have to manage a compromised pump every single day.
And this centers around the 2 and 2 rule, a 2-gram sodium restriction and a 2-liter fluid restriction.
Because salt acts like a physiological sponge inside the blood vessels. Wherever salt goes, water follows.
So we strictly limit sodium to keep their total fluid volume down, preventing them from overwhelming their stiff valves.
And the most reliable way for a patient to know if they're retaining fluid before their lungs fill up is through daily weights.
Absolutely crucial. Not weekly weights, daily weights. Taken first thing in the morning after using the bathroom on the exact same scale, wearing the exact same amount of clothing.
Because if a patient gains 3 pounds overnight, they didn't gain 3 pounds of fat. They retained 3 pounds of fluid.
It is the earliest red flag that the pump is backing up, allowing you to intervene before they end up back in the ICU on a ventilator.
So let's pull all these core concepts together. Stenosis is an open-door problem. The valve leaflets are stiff and refuse to open fully.
Right.
Aortic stenosis causes a harsh, high-pressure systolic murmur, severely limiting systemic blood flow, which triggers dizziness, exertional dyspnea, and chest pain. Mitral stenosis causes a low-frequency diastolic rumble, forcing blood to back up upstream, leading to stretched atria, dangerous AFib, and suffocating pulmonary congestion.
The ultimate takeaway we want to leave you with today is about clinical context. You aren't just memorizing audio clips and medication side effects to pass the NCLEX. When you place your stethoscope on a patient's chest and hear that chaotic whoosh, it isn't just a box to check on your flow sheet.
No, it tells a whole story.
It is the exact mechanical reason why your patient feels dizzy when they stand. It explains why their lungs sound wet. It dictates exactly why the provider ordered furosemide and why you are holding their nitroglycerin. You are using that sound to piece together the puzzle of the human being in the bed.
We want to invite you to watch the video on YouTube. Hit the like button, subscribe, and leave us a comment about what topics you want us to unpack next.
And definitely visit supernurse.ai for incredible resources specifically designed to help you build this kind of clinical judgment to become the super nurse you were born to be. As you head into your next shift or your next clinical rotation, leave with this final thought. We spend so much of our time and energy listening for the loud, turbulent whooshes of a failing valve. We train our ears to catch the friction. But consider what it means when a failing heart can no longer generate the sheer force required to make that sound at all. When the muscle gets so utterly exhausted that the murmur actually begins to quiet down. Sometimes, silence at the bedside is the most alarming sound of all.